Okay, I should start now. Hi, everyone. Good morning, good afternoon, and good evening, wherever you are. Thank you for joining us in this webinar, the first collaboration between MMIG, which stands for MICIDC Mycology Interest Group in Malaysia, and ECMID Fungal Infection Study Group, or EFIS. I would like to thank John and team from the EFIS for the collaboration and support in making the session possible. My name is Helmi, and I will be your moderator today. I'm an ID physician based in Kuala Lumpur, Malaysia, where I work at University Malaya. So our topic today is Candida Endocarditis, when yeast meets the heart. We have three excellent speakers today who will be sharing their insight on this important and challenging condition. But before we begin, just a few housekeeping points. First, please submit your question in the Q&A box. We will try to address as many as possible at the end of all three lectures. And for Malaysian participants, we will provide you with a link to the CPD point at the end of the lecture today. So without further ado, I would like to introduce our first speaker, Dr. Ng Rong Xiang. He is an ID physician, a lecturer, and my colleague at University Malaya. He has broad clinical experience and research interests, including antimicrobial stewardship, HIV, liver health, digital health, and infective endocarditis. He will set the stage for today's session by covering the epidemiology and clinical presentation of Candida and IE. Dr. Ng, the floor is yours. So I'll stop sharing now.
Hey, all right. Good morning, good evening, everyone here. So I'm gonna start my talk here. Let me just switch it to presentation mode. Okay, all right. So yes, good morning, good evening, and depending on where you are from. So can you see my screen here? I just started. Yeah. Okay. So yeah. So today my topic is about the epidemiology and the clinical presentations of Candida infective endocarditis. So
Hi,
yeah, I'm Ng
Rex.
Rong
We are
Xiang.
not
Yeah.
seeing your slides.
Oh, they says the screen are shared. You just hold on. Mhm.
I can see your slide, so just try to
Oh,
move it.
You can see my slide, yeah? Okay.
okay,
All right,
great.
sure. Then I
Yeah,
will
I
just
can
go
see.
on. Okay, yeah, sure. Okay. So yeah, so my name is Ng Rong Sen. Most people call me RX, just a treatment abbreviation. So yeah, I'm from the UM here. So yeah, same with Prof. Helmi. So yeah, so as I begin, I just want to tell you, actually make a confession, and I like to watch Dr. House, and sometimes I think fungal Candida IE can looks like this. But we don't have an episode of Candida IE in Dr. House episode. But I do like a few things about it, especially everybody lies. He like to say this word, but the data doesn't. And also, he will say that it's never lupus because a lot of time we will see systematic manifestation in infective endocarditis, but yes, it's never lupus. So same is it here. All right. So as an overview, all right, I'm gonna talk about epidemiology. What are the split of suspects and also crime scenes? What are the clinical features? All right, and with that, let us go into the risk factors, especially what are the motive and the vulnerabilities and the outcome of it. All right, so yes, let's start with epidemiology. So broadly, right, for infective endocarditis, we know about this for the past 30 years at least. And in the beginning, all right, the global incidence is about like 0.44 million. But look at 2021. If we were to look at the Institute for Health Metrics and Evaluation Statistics, as well as a few systematic review, the global incidence actually raised up to 135%, up to 1.04 million. And with that, the death rate is also increasing up to more than 100%, like 11% extra from the beginning. And yes, nowadays, it's more affecting the elderly or the adults. Gone are the days when we think it's only happening in low and middle income countries and also in the young. So not really. And in fact, nowadays we have an entity called healthcare acquired infective endocarditis, and it's relevant to fungal or candida IE. All right. So who are the usual suspects? Usually, we always think about staph aureus up to 33%, right? They are the leading aggression. And we sometimes, yeah, we may have some subacute organism, which are streptococci species. All right, they are usually in the dental, in the GIT tract. But we have the rising tract, which is the enterococcus. It can be from the genitourinary or gastrointestinal tract. Yeah, 1% may be has that group. But don't forget this group, all right? It could be culture negative, and in fact, some of them can be a fungi or candida. So yeah, they may be damaging the heart. So let me then zooming into the candida part. What are the hidden killers fact for candida IE, and why sometimes it's so difficult and we keep missing them, and we need to catch them at the right time. So as the candida grow or brew in the heart, all right, they are forming a vortex. So they have a confession to make. They like to, intermittently release in the vessels, and sometimes you may not catch them in the blood culture area. All right. So with that, they are really slowly building their base in your heart. And yeah, if you were to use a normal blood culture bottle, you may not catch them. If you are lucky, yeah, possibly you may catch them like Candida albicans. But if they are so difficult to grow, you may not catch them. And yes, they like to form biofilm, especially if there's any plastics or metals near the heart or something that close to your heart, like the central venous catheter. So yeah, they like to form a biofilm shield. With that, the antifungal molecule find it difficult to penetrate. Okay, so as they build their base, their their emboli or their vegetation become bigger. It will then move on to big vessels like the brain, causing a stroke, kidney infarction, or limb ischemia. And yes, we are still growing it in the blood fungal culture area, but by then usually we incubate for 30 days. If you get something at the end and you don't suspect it early, and yeah, it will really cause a devastating problem in the heart. Okay, so why is it so difficult to grow? Because it could be volume. We all know that when we take blood culture, we may not put enough volume, and sometimes we even try to use pediatric bottles. But for fungus, very tricky. They need like you only grow them one colony functioning unit per 5 mil. So yeah, if you don't have enough volume, you don't grow them. Next is the liability, the masking lie. All right, why the culture lie to you? Because if you see your patient very ill, yeah, you shouldn't wait and you started antifungal. But by the time when you take the fungal blood culture or blood culture, you really killed something, and yes, you can't grow them. And thirdly, they may shed in the vessel intermittently, yeah, because they are encased in the biofilm vortex. So yes, they may secrete intermittently. So yeah, if you do a blood culture bottle, just a single time, yeah, you may not catch them. And next, it could be a ghost species, Grapata, because they are quiet grower. They may give you a false CO2 alert, but may not grow anything. But other non-albicans, right? Like for example, olives, tropicalis, and whatnot, sometimes it may not be growing so easily and may take weeks to incubate it. Yeah, so you may miss it if you don't trace your cultures. Okay, so what are the risk factors? What actually makes it so easy to grow sometimes, right? So we have to look at the motive and opportunity. So who invited the killer, I would say. So yeah, the opportunity would be what is the open door that open to your heart. Number one, something that leads directly to your heart, the plastic high risk, the central venous catheter. So they reach near your heart, they can form something in the heart. Next, because as we treat the patient, right, we give them TPN. We want to treat our patient, want to build our patient's nutrition. So with the high glucose load, the yeast like to sit there and like to feed on that. So yes, with the C and also you infuse the TPN through the CDC. Yeah, so there's another risk factor for having this Candida IE. And of course, when patient is not well, you give broad spectrum antibiotic, you reduce the competitors, fungi then emerge, and finally, sometimes you do some surgery, especially abdominal surgery. There's a leakage into the gut to the vessel. So these are the opportunity. But what about the motive, right? Artificial targets, for example, prosthetic heart valve, no man land, no blood supply. So yes, they sit on it. Cardiac device as well, pacemaker leads. All right. And the other group, the IDUs group, the intravenous blood users group, non-steroid brewing, they brew the candida. And of course, if your patient is so immunocompromised, fungus like to grow on them. All right. But among them, some of the behavior of the IDUs, right, you need to suspect IE. Some of it is called the lemon juice catalyst. Why? Because if you want to dissolve the brown heroin or cocaine, you dissolve with lemon. You leave it in room air, candida growing it, then you inject, yes, you're injecting candida into your vessel. Next, they like to lick on their needles, right? All the bacteria like to grow inside when you do that as well, but the other one is Candida. Sometimes some of them to begin with, their immune system is not so good. They may have candidiasis. As they leak it, they inject it, and yes, they are injecting the Candida into the vessel. And next, the baker yeast adulterant. Why? That's the dealer's cigarette because they're not giving them the pure cocaine. They're mixing with baker's yeast. So yeah, perhaps not Candida, but is something like Saccharomyces IE. So if you see this, yes, it might suspect it. So you should stop treating the fever because sometimes you wouldn't see fever. But if you have such patient, always suspect their behavior in the ranches. Okay, all right. So what about the features? What about the signatures of fungal IE? So yeah, they are building it silently. But if you see the mass is so huge, more than 10 mm, you should start to suspect fungal IE or Candida IE. And up to 30%, there's no fever. Not like bacteria, you see the fever, you see a sepsis or chills and rigors. But in fungal or Candida IE, you may not see a fever. Okay, but the other thing is the embolic growth. Sometimes they like to go to the big vessel, so causing a massive stroke, kidney infarct, or large limb become necrosis. So yeah, you need to suspect that. And if you look into the eye, you see some fuzzy lesion or cotton ball lesion, then yes, you need to think that there is a possibility of fungal or Candida IE because they are building their second home in the eyes instead of heart. Okay, so what about comparison between fungal IE and bacterial IE? Embolic rate is higher. Fever is often absent in up to 30%, although the heart failure rate is fairly similar. But, well, you need to have a high index of suspicion based on the risk factors. Okay, and let me then move on to the echocardiography features. So, yes, we know that they like to form big vegetation. It can be up to 10 to 20 mm. So if you see a large vegetation, always think of it rather than a small shaggy vegetation in bacterial echo. And there will be a dense cauliflower pattern, or what I call as sessile mass, but often immobile, as opposed to bacteria is highly mobile. All right, and they are heavy and fixed to the structure. They like to invade the structures, okay, and going deep into it rather than the bacteria, they will destruct superficially. And lastly, because if they are so huge, they form a functional stenosis, something like obstructing the flow, like your left ventricular outflow tract obstruction. So yeah, you need to think about Candida IE if these are the features in echo. Why? Because you may not grow them in the blood culture. So if you see this, think twice. All right. So how do you interrogate them? Comparing between transthoracic and transesophageal echocardiogram. And also you must consider your host, whether your patient is having a native or prosthetic valve, because the game plan is different. If just a native valve, you use a TTE, yeah, you can detect up to 70%. But if it's a prosthetic valve, actually it's only half-half. 50% you may miss it. However, if you have a strong index of suspicion, right, if you do a TOE, you increase the sensitivity up to 92 to 96%. So trust your instinct sometimes. Right? So a negative TTE, I need to stress that it doesn't mean there is no bug or no fungus. It just means that it's smarter than our equipment. So yeah, always, you know, keep on your toes. Okay, so why is that so? What is this for alibis of Candida IE and their features? Number one is the acoustic shield, because when you have a foreign material, something is hiding behind it. So if you just do a transthoracic, you may not see the thing behind the shield. All right. Next is the mural wall. Most of the time, technician and us previously when we train for echo, we pay attention to the wall. We seldom pay attention to the wall. So that's how we miss it. Okay. Thirdly, which is the silent part. They, instead of forming on top, they invade below it. So yeah, we may not see it if you don't pay attention. And finally, if you don't see it at all, doesn't mean there's nothing. Because why? The emboli has traveled to the big vessels. Yeah, so these are the four features why the echo may fool you as well, and the echo may lie to you. But let's say if the echo is blind, we should again think about extra things to help us to diagnose. First of all, it could be a cardiac CT. But if you were to do a cardiac CT, always communicate with your radiologist to think about thin slice CT or thin slice reconstruction. By doing so, all right, you can detect complications actually better with it. For example, perivalvular abscess, pseudoaneurysm, fistula, or structural problem. So you couple this cardiac CT with your echo and clinical suspicion. Next, of course, is PET-CT, our favorite. PET-CT is better if it's a prosthetic heart valve or any materials into the heart. For example, CRTD or pacemaker. All right, and you look at the tracer and you go and target that. Yeah, but of course, you may need some special diet modification like keto diets. All right, so the next one is white cell scan, the bloodhound. So anything that goes high over there, they may be the house of the fungus, right? So yeah, you can think about these three things. But of course, if the culture still didn't show up, yeah, you can consider some extra help. For example, serum markers, right? Like beta-glucan. All right. Yeah, possibly it can increase your sensitivity and specificity, but of course, bear in mind about false positivity in those undergone surgery, hemodialysis, or received blood products. But problem is, if you have a cardiac device, sometimes peroxidosis like to sit there, and this one is actually low sensitivity for peroxidosis. Other things like T2 candida, at least they can detect these five species: albicans, glabrata, peroxidosis, tropicalis, cruzi, up to 91% sensitivity and 99% specificity. But if they only these five, so other things you may miss it. I'll show you what the other Candida species, okay? It's something like the MRI of the organism, not the body, but MRI of the organism. They put this cartridge into the machine. Okay? Next is PCR. Think about PCR to be to target the primers of Candida or something like what we call metagenomic, but that's a bit broad. But think about PCR. You can run the PCR in the blood or tissue. Yeah, so yes, it may help with your diagnosis, but of course, send it before formalin if you are talking about WAF sample. Well, galactomannan is most of the time for aspergillus, but I want to stress that if the patient is on treatment, let's say if you are talking about galactomannan, yeah, you may not get any markers from that. It may show negative, right? Okay, so candidemia dilemma, yeah, we often worry about this. The risk is actually rather low, like 6% at low risk zone. But if you have a prosthetic material, the risk increase up to 36.4%. However, globally, be it in the American or European, historically, we always say that we tend to do if there is a risk. Okay? But if you have this red flag, don't wait. You should request an echo. The red flags are prosthetic valve for devices, persistent candidemia more than 5 days, persistent fever, new murmur or new onset heart failure or any embolic phenomenon. Okay? Most importantly, if you don't find any source at all, you should still request an echo. All right. Yeah. So who are the syndicate? Okay. Big boss, the kingpin, Candida albicans, up to 60% of the cases, large and complex biofilm, okay, and friable vegetation. Mortality up to 80%. Okay, but good thing is azole susceptible, but we don't usually use that to treat, but I'm just showing you. Right, peroxidosis, they are the hardware specialists. They like to stick to hardware. Yeah. And next is opportunists, the tropicalists. They tend to be in the immunocompromised group. All right. And there's a growing trend in Southeast Asia and Latin America. Okay. All right. But just to say that for peroxidosis, they are emerging in candidin resistance. So yeah, sometimes if you use that as an empirical therapy, you may not hit it until you get the culture itself or the organism, right? Other things, some of these have changed their name, all right? Previously known as Candida glabrata, now it's Nacasomyces glabratus, up to 4 to 9% of cases. But good thing is that it may be less associating with IE because they cannot form a stalk. Yeah. So never say never, but if you see glabrata, less chance of IE. And the new track, Candida auris. Well, yeah, so worried about this because it's a drug-resistant candida. Basically, it's very difficult to treat. Okay, all right, but they like to colonize the indwelling lines. Yeah. So other things you may heard about Candida guidomondi. Now the new name is I don't know how to pronounce this. Previously it's Candida krusei, now it's Picha kudazivai and Candida dubrinensis. So there are still other names, but don't dismiss them. All right. So yeah, I'll just quickly run through the treatment gap rather than tell you how to treat because my other colleagues will say so. So we all know about this. This guideline is published by the Candida group in the 2025 Lancet. All right, we know we should have liposomal amphobe, flucytosine, or high-dose echinocandin. Everybody can mention that. But if you look at the access, all right, not everywhere can access to it. So there is an access disparity. All right. Yeah, we also know, yes, we need to refer to surgery to do things concurrently to tackle this issue. But in reality, only 40% get to do the surgery. Why? We all know that there's a selection bias because if the patient don't survive well, yeah, so ill, so critical, they tend not to undergo the surgery. Okay. But if you do look at this data, you may think that, yeah, not too bad because these two authors find that no difference. But of course, if you look at the trend, if you do surgery, kind of benefit, although no difference statistically. But you must always know that in any form of surgery, there's always a selection bias. So it may not reflect that. Okay. So the question is you need to get the right patient to refer to the surgeon at the right time, not too ill, right? And also how fast they can operate. Yeah. So and most at the end, so the summary is that the killer is the candida, drive most of the fungal IE. So I wouldn't really be able to tell you who is the low risk or high risk, but the moment you see a candida IE, it's often a high risk already. And the team. All right, candida is not a uniform organism. You can't fight always the same way as albicans. You need to know their last name. Okay, and the blind spot. If you have a strong suspicion, your TTE, transthoracic echo and blood cultures are negative, we still have a strong suspicion, go beyond that, your transthoracic echo or other form of diagnosis. And yes, we have a better diagnostic and drug, but the mortality is still high. Yes, because the tools don't save the patient, our decision do. And yeah, most at the end already, the case should be closed now, but well, not really. We solved the what, we know what is the pathogen, the diagnostic, and the treatment, but we haven't solved the where because access is a problem and that determines the outcome. And the reality is the better tool only work if the patient can reach to them. So yeah, it's not lupus. Anybody still think it's lupus? I hope no. With that, I thank you for your attention. Thank you.
Thank you, Dr. Ng, for the excellent overview. Next, we have Dr. Lim Kah Chuan, an infectious disease physician at Hospital Sedang. He is actively involved in national initiatives, including contribution to national antibiotic guidelines, as well as teaching in infectious diseases and HIV. Hospital Sedang, where he is working at, is also a national referral center for cardiac diseases, including infective endocarditis. Today, he will be sharing with us local experience in the management of Candida IE. Dr. Lim, the floor is yours.
Thank you, Prof. Helmi, for the introduction. Can you all hear my voice?
Yes, and we can see the slides. Thank you.
Thank you very much. So I'm Lim Casey. I'm an ID physician currently in Hospital Sedang, which is a national cardiac center. So today we'll share some local experience in the management of Candida IE. Slide. Okay. So I have three cases here. I'll start off with the first case, which was referred from Hospital Kuala Lumpur to Hospital Sedang. So this is a 56-year-old lady with a comorbid of type 2 diabetes, hypertension, and end-stage renal failure. More dialysis via the left IJC, which was inserted in June 2023, as there's no suitable vein for AVF creation. So a month later, in July, she presented to HKL with a fever for 2 weeks associated with chills and rigors. Clinically, she's stable, under room air, not in shock. And the diagnosis of CRBSI was made, and the blood culture upon admission was a Candida parasidosis with the MIC as shown here. As if you compare to the UCAS susceptibility breakpoint, you can realize the fluconazole 2, which is almost sitting at the on the dot, on the fence. So the left IJC was removed on day 3 of admission. She was started on IV fluconazole, but she suffered from persistent candidemia despite antifungal and the CVL removal. And further assessment actually revealed vegetation at the mitral valve with the both anterior and posterior valve size of more than 1 cm per square. And eye assessment wise, there's no endophthalmitis, and CT thoracic abdomen pelvis only shows some thickened bowel, which suggestive of inflammatory colitis changes. And CT brain also had a recent right frontal lobe infarct. So a diagnosis of Candida parasilosis native mitral valve endocarditis was made. Antifungal was switched to amphotericin B. We are using conventional M4B here. Liposomal M4B is not widely available, and together with the full cytosine for the synergistic effect. And the patient was taken over to my hospital cardiology and cardiothoracic team, and she proceeded with the mitral valve replacement after 3 weeks of amphotericin B and flu cytosine. And this is the intraoperative tissue HPE, which show actually fungal hyphae and budding yeast at the mitral valve. And the mitral valve tissue culture, which grew Candida parasilosis, which correspond with the blood culture results. Post-operatively, M4B and cytosine will continue. Echo post-op reassessment show that the MVR is intact with no perivalvular leakage, but she suffered from poor GCS recovery. And because of that, MRI brain was done and show actually multifocal infarct, some of which are acute with subacute intraparenchymal hemorrhage. Unfortunately, she passed away because of these embolic complications. So the challenges in this case, I've divided into diagnosis and management. Number one is the diagnosis part. There's slight delay in getting the echo to be done. So therefore we need early suspicion of endocarditis in the persistent candidemia, as highlighted by our previous speaker as well. In terms of management, in terms of choice of system antifungal, we know that we don't use azole monotherapy for Candida endocarditis. Our local CPG 2017 endocarditis guideline recommended either amphotericin B with or without flucytosine together, or high-dose echinocandin. With regards to the timing of surgery, especially, is a bit tricky. I know it's data are sparse, especially in the background. This patient had a recent cerebral infarct even before the surgery. Therefore, the risk of hemorrhagic transformation is high, which actually occur after the op. Our local guideline generally recommends early surgery within a week or two for Candida IE. Yeah. And we have a second case, which actually was managed in University Malaya before being transferred to Hospital Sedang. We'd like to thank today's moderator, Prof. Helmi, for the case details at the UMMC. So he is a 52 years old gentleman working as a security guard with an underlying medical history of sickle cell disease, but unfortunately defaulted since year 2004. So he presented to UM in December 2021 with the symptoms of mainly epigastric pain, abdominal bloatedness, and discomfort, associated with reduced effort tolerance for 3 days, lethargy for 5 days, as well as vomiting for 2 episodes. Of note, he had also jaundice for 10 years, but did not seek any medical attention. So because of the abdominal symptom signs, so a CT abdomen pelvis was done, which show hepatomegaly, but no CT evidence of biliary obstruction. And actually, there's an absent spleen with a focal cause calcification at the splenic bed, may represent autosplenectomy. So technically, he is immunocompromised because of the hyposplenism. He subsequently had worsening respiratory distress requiring intubation, mechanical ventilation, and vasopressor support with rapid drop in HB hemoglobin requiring multiple packed cell transfusion, treated as acute sickle cell crisis with acute chest syndrome with vaso-occlusive crisis, hemolysis, complicated with severe hepatitis and non-oliguric AKI. You must be wondering why this case is in the IE webinar, but I'll show later. Which they done the echo actually because of the clinical findings of pansystolic murmur, which show actually mobile mass attached to the chorda tentina or tricuspid ward with the size of 1.8 times 0.7 cm, as well as trivial TR, trivial PR, and AR. Blood culture taken on the same day grew Candida albicans, susceptible strain. So a diagnosis of Candida albicans native tricuspid valve IE was made. High-dose echinocandin was started immediately, and the case was referred to cardiothoracic UM, and it was decided to be conservative and continuation of systemic antifungal. Further assessment, eye assessment, there's no evidence of endophthalmitis, no rough spot. Repeated blood culture 4 days after the antifungal, managed to achieve culture clearance, and there's an echo repeated after 5 days after treatment, which show the same mobile mass with a similar size. And to make things worse, he developed seizure on day 11 of admission with a suspected septic emboli to the brain. The contrasted CT brain showed that there's a possibility of hemorrhagic metastasis to the left parietal, right frontal, as well as the great white matter junctions. So because of all these embolic complications, the prognosis was guarded. He was extubated with poor GCS recovery of E3, V1, M5. He AOR at own risk. The family decided for at own risk discharge from the medical center. Before came to my hospital on the same day. The repeated blood culture here, fungal blood culture here is no grow, and we switched to M4B and full cytosine again. And unfortunately, he passed away 4 days after admitting to my hospital. So again, challenges in this case, for this patient, there's lack of traditional risk factors as presented by the previous speaker, and the atypical presentation of Candida endocarditis in this patient, as the main presentations were related to the sickle cell disease, as well as the management into row operation in Candida IE, which was partially mentioned by the previous speaker about the benefit as well as risk of operation, especially in this patient, which is very high risk because of the sickle cell crisis with hyposplenism and the septic embolism. And probably we can discuss later about choice of systemic antifungal, because we all know that echinocandins does not penetrate CNS well in patients with septic emboli to the brain, whether we should be considered amphotericin B earlier. Okay, there's some challenges in this case. I come to my last case. This case was totally managed in the University Hospital or University Kebangsaan Malaysia, UKM. We would like to thank Associated Prof. Patrick, ID physician there, for the case details. She's a 63 years old lady with a type 2 DM, hypertension, dyslipidemia, end-stage renal failure again, with the hemodialysis via the left IJ permanent catheter since January 2024, ischemic heart disease. So 4 months later, she was diagnosed with CRBSI complicated endocarditis. The blood culture, central and peri, grew Candida parasilosis, similar to my first case presentation earlier, susceptible to fluconazole. And the transesophageal echo shown posterior mitral valve annulus hyperechogenic mass, 1 times 1 times 0.9 times 0.6 cm, which was commented by the cardiologist to be inconclusive whether this is representative of vegetation or not. So she was started on M4B and flucytosine. The permanent catheter was removed, and because of the inconclusive echo, PET-CT scan was done a month later. We show hypermetabolic focus at the mitral valve region, suspicious of infected endocarditis. Lucky for her that there's no evidence of active disease elsewhere from the PET-CT. Operation was offered, but the patient refused, and she was treated with amphotericin plus flucytosine for 40 days as inpatient, and she managed to achieve culture clearance after 2 weeks, and followed by oral fluconazole for 6 months. At the end of 6 months, patient was asymptomatic, able to tolerate hemodialysis without any features of intradialytic hypertension or Chio's rigors. The repeated TOE shown the similar size posterior mitral valve lesion, which lead to PET-CT reassessment. Unfortunately, the focus has increased intensity compared to the previous ratio. Again, the surgical intervention option was offered to the patient, but the patient still refused for op. She's still under our nephrology follow-up at the HUKM, and so far there's no relapse of infection so far after stopping the fluconazole. Last seen actually early of this month. Okay. For diagnosis challenges in this case, again, the TOE was inconclusive, and there's a role of PET-CT, as this case highlighted, for both initial diagnosis as well as reassessment of endocarditis after treatment. And for patients with Candida IE who were treated conservatively, usually there's another interesting discussion will be about the duration of antifungal. Generally speaking, many guidelines recommend to consider lifelong suppressive antifungal therapy. So far for this patient, the antifungal was stopped after 6 months of fluconazole, and so far there's no relapse of the disease. So I come to my last slide. Majority are healthcare associated infections, as you can see. And we must always suspect Candida endocarditis in patients with persistent candidemia or patients with clinical signs or symptom signs of endocarditis like new onset murmur or stigmata or IE. And as shown here, Candida IE has very high risk of embolic complications. So always look for disseminated sites of infections. And when we start antifungal, we must always consider pharmacokinetics of the antifungal as well. So because icosapent have poor tissue penetration, especially to the CNS. And as highlighted by previous speakers, Candida IE has very high mortality. Out of the 3 cases I presented, the mortality is more than half. Actually, I have more cases in my series, but a majority of them die. So the mortality is very high. Okay, but lucky to say, it is not common. Of my 5 years working in this cardiology center, there's less than 5 to 10 cases of Candida IE that we encounter. Okay, with that, I thank you.
Thank you, Dr. Lim, for the excellent sharing. Our final speaker is Dr. Claudia Bartalucci, an ID physician and a PhD candidate from the University of Genoa, Italy. Her work focuses on invasive fungal infection in immunocompromised and critically ill patients with strong clinical and research experience in this area. She will be presenting on the European perspective on Candida IE. Dr. Bartalucci, the floor is yours.
Good morning, everyone. I'm Claudia Bartalucci. You can see my slide. Okay. I'm Claudia Bartalucci. I'm a physician. I'm an AD specialist working in Genoa. I'm a PhD candidate, and today I'm going to speak about the European management of Candida endocarditis from a clinical standpoint. This is my disclosure. So first of all, we are going to start with the European tools. As you all know, we have guidelines addressing infective endocarditis, also including a part dealing with Candida endocarditis. The new published global guidelines from ACMM dealing with invasive endocarditis and also invasive candidiasis and also infective endocarditis due to Candida species. And I'm also recommending you this narrative review written by people from different European study group that have addressed the issue of Candida endocarditis in a very well done way, so we can manage this difficult to treat infection with this tool. And let's start with the first problem about Candida endocarditis. As you have previously mentioned, the problem is the suspicious of the diagnosis and the difficulties in diagnosis, and data from the literature have said that the mean duration of symptoms before hospital admission in this setting is very long, up to 71 days in some cases. So people are staying home with symptoms or without symptoms for a very long time before seeking for medical advice. And fungal endocarditis have been considered as initial diagnosis only in 18% of the cases. So we need a high clinical suspicious to start the workup and the management of this syndrome. And what about microbiological diagnosis? Of course, guidelines suggest that blood cultures are the gold standard for diagnosis. And one of the most important issues about dealing with invasive candidiasis is the screening for Candida infective endocarditis during candidemia. And we can see a slight change over time from the European recommendation about it. We know that the incidence of Candida endocarditis during candidemia, it's not so high and can vary from some reports. So it accounts from 2 to 6% of the cases. And in 2012, the ASHMID guidelines about invasive candidiasis have addressed to screen all the patients with candidemia for a localization in the heart, while the more recent ACMM guidelines from 2025 suggest considering screening of the heart, the localization as endocarditis only in case of suspicious, so with clinical signs, in case of persistent candidemia, and in patients with risk factor as valve disease or cardiac implantable devices. And another issues about blood cultures is the low sensitivity. We know that the sensitivity has improved over time from the 54% in the previous century to the 90% from now in case of endocarditis, and we have a new data on the new due criteria in which Candida have been recognized as a typical pathogen for prosthetic valve endocarditis, so considering is for the diagnosis in case of risk factors. Persistent candidemia, it's a problem. It can vary in incident in candidemia, and positive blood cultures lasting for more than 3 days after adequate antifungal therapy occurs in quite high cases of Candida endocarditis and had been associated with worse outcomes. About non-cultures-based tests, as we already mentioned it, there is a lack of specific study addressing the role of this kind of test in Candida endocarditis. They can be an additional tool in case of negative blood cultures, mainly. And we know that beta-D-glucan, one of the most studied one, can be an adjunctive tool when blood cultures are negative, but it can have pros and cons. It can be positive in cases of fungal endocarditis. In this system, in a systematic review, had been positive in 88% of the cases. But we know that beta-D-glucan can have low specificity. It's a pan-fungal marker, so low specificity intrinsically in the test, and also reduced sensitivity in some species like Candida auris and Candida parapsilosis. And also it has a variable kinetics, so using it as a prognostic factors to manage treatment is kind of critical. Another issue can be the T2 Candida panel that have been reported in some case report as a prognostic tools for the management of the continuation of the treatment. In a case report, it has been used to assess treatment response in a prosthetic valve Candida parapsilosis endocarditis, but we don't have clear evidence about its universal use in Candida endocarditis. So moving to diagnosis, we have already mentioned that the characteristic of fungal endocarditis can be similar to the bacterial one, but has some points that could be suggestive for a fungal origin, like large and highly mobile vegetation, and the main size could be also very, very huge. And also we have some other tests like PET-CT scan that has been integrated in clinical practice in the last decades, useful for in case of echocardiography when it's conclusive. And we have some reports about the use of the PET-CT scan during Candida endocarditis in some case series, and the false negative results were mainly due to inadequate preparation to the test and native valve endocarditis. So moving to the most important part of the presentation, these are the recommendations about the treatment, especially the surgical treatment for Candida endocarditis. We know that valve replacement have been recommended over time for this kind of clinical setting, and the reason for the recommendation to get a surgical management very prompt and very soon after the diagnosis of Candida endocarditis is that there is a high mortality rate of this syndrome. We have limited activity of some drugs within the biofilm of the vegetation and also of the prosthetic devices. In case of persistent fungemia, it can help manage this worrisome issue. and also for the risk of complication like abscess and embolization. But mainly the problem with Candida endocarditis is late relapse, so surgical management can help manage late relapse. And this is the traditional rationale about this recommendation. However, the surgical management of Candida endocarditis have been based, and the recommendation have been based mainly on observational studies, case reports, small case series, clinical experience. So we don't have comparative randomized clinical trial assessing the efficacy of surgical management. And in the reality, we can acknowledge that not all our patients are going to have a surgery for this kind of clinical syndrome. Here you can see a revision of the literature in which almost 40% in the real world patient with Candida endocarditis have been undergone two surgeries, so not so high percentage of people. And here you can see evidence-based from observational studies, of course, dealing with the impact of surgical management in Candida endocarditis. In green, you can see the studies in which a benefit have been demonstrated with the surgical management and also combined with antifungal therapy for some patients. In yellow, orange, you can see the studies in which a benefit have been observed, but not in a statistical significant way, and in red the studies in which a clear benefit of the surgery have not been demonstrated. So the literature is conflicting about the recommendation of the guidelines and about the real benefit of surgery. But we have to point out that our observational studies with inner bias, and so clear recommendation it's hard to do in this setting. Moving to the medical management, we know that we have two approaches. The first one is the induction antifungal therapy that we have to start after the diagnosis, and then the chronic suppressive therapy aiming to reduce relapses and worst outcome, especially in the setting of prosthetic valve, both if the patient is undergoing or not undergoing surgery. And in this setting, choosing the antifungal could be done based on the antifungal susceptibility testing. So we have the pathogen, and so we can check for susceptibility to be sure that our treatment could be effective in the setting of our pathogen. And about the induction therapy, historically, amphotericin B deoxycholate have been the treatment of choice. Now the liposomal amphotericin B is preferred mainly for safety, for the heat safety profile. We reduce nephrotoxicity and the reduced infusion-related toxicity. And also it has an enhanced biofilm activity compared to the deoxycholate, which can help in the setting of Candida endocarditis. Historically, flucloxetine had been added to amphotericin B for the induction treatment. For the potential synergism in vitro, we have to be acknowledge the toxicity also of flucloxetine in this setting. And this recommendation has been based on a meta-regression analysis published in many years ago, in which the combination therapy of amphotericin B and flucloxetine has been used as the most common combination treatment, showing a benefit. So this is probably the reason why we're using this recommendation for the induction therapy with this combination. But what about the echinocandins? We know that they have a safety profile, so they have been used for Candida endocarditis increasingly during the last decades. As you can see from the beginning of this century, the percentage of use of echinocandins in this setting was almost 20% and up to 80% nowadays. So we are using echinocandins for Candida endocarditis very commonly in our real world life as a clinician. And the reason why we are going to we have done this shift and we are choosing echinocandins for treating Candida endocarditis is probably because they are rapidly fungicidal agent. They have a safety profile, so decreased nephrotoxicity compared to amphotericin B. They have similar efficacy in comparison to amphotericin B for treatment of candidemia and invasive candidiasis. So we have extend this recommendation and this safety and efficacy data also for Candida endocarditis. They have a very increased activity against the Candida biofilm, so it's a good tool for managing this syndrome. And we also have done some experience. We had some experience with higher dose of echinocandins, and we know that they can safely use a higher dosage for treatment of Candida endocarditis. But here I'm showing you some data about the comparative use of echinocandins and amphotericin B, so the two available induction therapy. These are data from retrospective studies on Candida prosthetic valve endocarditis from Spain and France, including 46 cases of Candida endocarditis with an induction both with amphotericin B compared to echinocandins. As you can see, the results are favoring amphotericin B alone with a better 6-month survival rate than echinocandin alone, so apparently favoring amphotericin B in this setting. While if I'm presenting you this very newly published comparative studies from the Swedish group, from the Swedish Registry of Endocarditis, including 51 episodes of endocarditis in 38 patients, including also 13 relapse, comparing echinocandins with other regimen for treatment of Candida endocarditis. As you can see, echinocandins were together with amphotericin B the most common used agents, and the characteristic of the population include were quite similar, except for echinocandins that have older patients and also more frequently nosocomial endocarditis, and also have quite higher burden of comorbidities, while there is no difference about the type of endocarditis and the pathogen involved. And here you can see the results. The management was quite similar because there were similar rates of adjunctive surgery therapy in all the groups. So overall, 41 patients undergone surgery in the echinocandins, amphotericin, and indazole group. No combination therapy were done for the echinocandin group, while amphotericin B was frequently used as a combination regimen. And here you can see the efficacy results in terms of treatment failure, but also mortality, that didn't differ so much between the groups, so not in a statistical significant way. So it's probably these results show us that we can use echinocandins also in patients with comorbidities for treating Candida endocarditis. And about fluconazole, we know that it has a limited role as an initial therapy, but we have data from a meta-analysis including 64 cases of Candida endocarditis treated with fluconazole with no surgery, with a very high rate of cure and improvement of the syndrome. Also in immunotherapy with 58% of the patient cure, but we can see the results of the combination therapy with fluconazole. So fluconazole with another agent have a very high rate of cure. So we can use fluconazole for sequential therapy and for long-term suppression. And about the length of the treatment, we know that we have few data for strongly recommended a fixed duration for treatment of Candida endocarditis. We know that for the prosthetic valve, the induction treatment should be at least 6 weeks. and a long-term suppressive treatment is needed, both for if patients have undergone surgery. There is no clear recommendation about the length of the suppressive treatment after surgery, maybe 1-2 years, while probably a lifelong therapy is needed, is recommended from most guidelines if the patient has not been operated. For Candida endocarditis on native valve, the evidence is still not clear. We know that probably at least 6 weeks for the induction treatment is needed. If the patient is clinically stable, so for example, he has negative blood cultures and the patient has an infection from a susceptible strain, we can have a step-down therapy with fluconazole or other azoles to continue therapy. And there is no clear evidence on suppressive treatment if the patient has performed surgery. So the importance of lifelong suppressive therapy, as we have previously mentioned, is to reduce the recurrence that are very frequent in the setting of Candida endocarditis, up to 30% of the patient, and can be very late in time after diagnosis, in some cases also 9 years after the cure. So long suppressive therapy means to trying to reduce the recurrence, and azoles are very well tolerated to use as a maintenance therapy. And here you can see the results from the previously mentioned retrospective studies conducted in Spain and France, when we have used a suppressive treatment independently of if the patient have performed surgery or not. The outcome were better with suppressive treatment with azoles, and also few discontinuation for adverse event have been observed in patients treated with long-term suppressive therapy. So moving to the recommendation from the guidelines, here you can see the differences between the guidelines, the ASHMID and the IDSA for the treatment of invasive candidiasis, and also the S guidelines for managing of infection endocarditis, and the newly published ACMM guidelines on invasive candidiasis. I want only to point out that the recommendation about the initial treatment is mainly dealing with amphotericin B in combination with fluticasone, and also as an alternative, most of the guidelines recommend echinocandins. There is no consensus, clear consensus about the dosage of echinocandins. Some guidelines recommend a higher dosage, for example, the IDSA and the S guidelines, while the ACMM, the last published ACMM, only marginally recommended higher doses. So the standard therapy for the induction could be standard dose of echinocandins. For step-down therapy, we know that, for example, the IDSA and the ACMM point out that we have to have some criteria for performing a step-down therapy with azoles. For example, the clearance of candidemia, it's addressed by the guidelines. The surgery has been recommended within one week early for by most of the guidelines, and for the length of the therapy, as we previously already mentioned, the induction period is about 6-8 weeks. And also there is the indication for lifelong suppressive therapy if the patient had not undergone surgery. So what we are doing with our management of Candida endocarditis, probably we are doing quite an improvement in the management, because mortality is improving a little over time. So today the mortality has reduced, maybe thanks to the advances in diagnosis and treatment, and the mortality in the Micendo studies have been reported up to the median time to death of 66 days. So we can do other other something else for our patient nowadays, and this is my closing slide. We have to for sure identify susceptible populations, so prevention in the high risk patient, for example people with implantable devices and valve disease could have our attention about the diagnosis. We have to try to our better for an early diagnosis and an early medical and surgical treatment. And also the role of long-term follow-up and monitoring. We know that relapse can occur very late in the course of the infection. So, for example, the PET-CT scan can be useful for monitoring high-risk patients, especially with prosthetic valve endocarditis without surgery. And the future will probably be the role of new antifungals, for example, rezafungin, and the modified biomaterials to reduce the risk of infecting endocarditis in patients with cardiac prosthesis. Thank you for the attention.
Thank you, Dr. Claudia, for the comprehensive European perspective on the management of Candida IE. We will now proceed to the Q&A session for the next 20 to 30 minutes. So I would like to invite all the speakers to turn on their camera for the session. So what I will do is that, so before that, I have shared a speedy link for Malaysian healthcare workers for those who want to actually apply for CPD points. So for these Q&A sessions, I will divide them into a few teams. So I think that the first team, I would actually look into the epidemiology and the detection or diagnosis of Candida IE. So the first questions, I'm just going to actually link up a few questions. So given the challenges in isolating Candida from the blood culture, how can fungal biomarkers or PCR-based tests be used pragmatically to support the diagnosis of IE, Candida IE? Is there a framework we can use as clinician if we suspect Candida IE? Like in one of the questions, they say that can we use a single high BDG level with one single blood culture fungus, positive fungus, to say that the patient is at high risk of Candida IE? Dr. Rongxiang?
Yes, I mean, actually, what we can do is that if we have the high suspicion, we know that the culture going to be negative, we should, take as much as volume as we can. That's number one. Put inside the bacterial fungal culture bottle, fungal blood culture bottle itself as well. And if we can, we should actually try to communicate with the microbiology lab. If we could kind of store the volume, because some samples like blood, you can't store for more than 24 hours. But if you're doing, let's say, for tissue cultures, like the WAF and whatnot, you can store first and always check with your patient if they can pay. If you didn't grow anything, you still have a suspicion if they can pay later, then yes, when you store the sample as they freeze it under negative the 80 degrees Celsius. That's how they do it in the lab. Then subsequently you can send. Pertaining to the markers, yeah, it's the same thing as well. If the patient can't pay first, if you can't store too long, there's no point. But if they can pay, yeah, you could. Pertaining to cutoff value, not really. But if you see the higher the value is, especially let's say I'm just saying that to Manan and whatnot, and the BDG, if more than 5 times, 6 or 7 times, then yeah, that is very suggestive of some form of deep-seated invasive infection has happened. So yeah, perhaps you can have a baseline, and once you treat already, the culture is still negative. You could kind of repeat that. BDG may not be affected by antifungal, but galactomannan, yes. So if you see perhaps like coming down trend, yeah, maybe you can say that. But true enough, there is no cutoff value. But I had an experience by using the higher the number is, like more than 10 times or 8 times of the upper limit. Yeah. That's all for my answer. Yes.
Thank you. So for the benefit of the non-Malaysian clinicians and healthcare workers, the serum BDG is not routinely available in Malaysia. So we need to source it out to a few centers in Kuala Lumpur to have this tested. Does Claudia or Nim have any input on this, on how to use BDG or non-culture method? Is there a pragmatic way of detecting Candida or suspecting it using the biomarkers?
I think that they're only adjunctive tool. There cannot, we are dealing with definitive diagnosis. If you are suspecting invasive candidiasis, you can also have other localization, for example, localization in other organs, deep-seated candidiasis. So it doesn't mean there is a definite diagnosis. For sure, it can help in case of suspicious, but it's not a definite tool. Also, we have to acknowledge the limitation, no? So the low specificity and the low sensitivity, so using it very carefully.
Thank
Yeah,
you.
BDG not available in my center, so we don't usually use it, and it's not sensitive nor specific for Candida IE. So yeah, so we don't use it.
Thank you. I'm just going to have a follow-up question based on a few, two questions that I saw in the chat box just now. So I think that when we have a patient who came with septic shock, for example, we usually ask the doctors or physician to take at least 4 to 6 normal blood culture for this patient to increase the yield for the bacterial infection. But how many microephylytics of fungal bottle should be included in this? Should it be included in the 4 or 6, or this is 4 or 6 plus another 2 fungal blood culture to improve the detection of candidemia or invasive fungal infection? Maybe I can ask Rongjiang, and then Lim and Claudia can add on to this.
Yeah, so my take is the more the better. So if you can take more with the 3 samples, yes, I would. Especially if there's a central line, yeah. So there'll be 1 from the peripheral, 1 more from the central line. Let's say blue color and the white color. Yes, personally I do that. And with enough volume. Yeah. So you use the vacuum cleaner to let it suck until it's dry or by dropping. So you should I personally do that if I were to take the culture myself. Yeah.
Lim?
Yeah, for septic shock, generally we recommend at least two separate pairs of cultures. Usually for micro F, it's tricky. Sometimes bacterial culture can grow there as well. So we will, if suspected fungal blood culture, we'll send one more fungal blood cultures now. Yeah, that's the routine practice.
Anything to add, Claudia, on this?
Not from my mycological point of view, from the clinical point of view, only to stress the importance of blood cultures before starting empirical therapy. We know we have recent data from a studies published in general for infective endocarditis, in which starting empirical therapy didn't show very so much benefit in patients with infective endocarditis in general, not for Candida species. So stressing this issue to do everything we can for the diagnosis before starting empirical treatment. Afterwards, we don't have so much chance to reach a microbiological diagnosis, and we know that sensitivity of blood cultures depend on the number of the sets. So ideally 3 sets, it's better, and it's better to wait to do another set also during septic shock, but also only with fever, with suspecting endocarditis, just to reach the diagnosis. So only to point out this issue.
Thank you. I'm just going to ask a follow-up question there to you, not a follow-up question, but a new question to you, Claudia, because I'm going to move on and pivot to the antifungal treatment. First, the antifungal choice. So I think that you have clearly illustrated just now the treatment approach, but I just feel that it is nice to actually have it reiterated. So in terms of the initial management for Candida IE, what kind of combination therapy or what kind of approach we should actually use? Do you use mono or combination therapy? And if it is combination therapy, what are the agents that we should actually be using? And can azole be used as part of the initial combination therapy?
Thank you. In my experience, but also looking at the evidence, there are most observational studies, we can say that echinocandins, mainly monotherapy, have been preferred over the times to treat patients with comorbidities. For example, patients with kidney problems or comorbidities or aged patients, so in elderly, as you have seen in the observational data that I have shown, mainly echinocandins have been increasingly considered the preferred regimen in this setting. And I can say also in my experience, when we have some patients with comorbidities and problems, underlying problems, maybe the monotherapy with echinocandins that have been recommended as a monotherapy by the guidelines, so not as a combination therapy, can be used for the induction treatment. Historically, the amphotericin B in combination with fluticasone, despite the evidence of the efficacy of this combination is low, had been considered the alternative or the first line treatment. And they are the main combination. The combination with azoles for the induction therapy have not been addressed by the guidelines and also by most of the literature that I have read for this presentation and from the literature about Candida endocarditis. So probably azoles are preferred for the maintenance therapy, while for the induction they have mainly quite a role, not an important role in the induction treatment. Echinocandins in combination, I don't have experience for the induction treatment, and I don't have experience in which agent for combination because it's not addressed from by the guidelines. But discussion in the scientific community have been for a long period about the higher dosage, so we probably need an explanation about that, more clear evidence about the benefit of higher doses. The new LCMM guidelines didn't recommend it very strongly, a higher dosage for Candida endocarditis, so we can use echinocandins as a standard dose. We know that higher dose it doesn't hurt, but we don't know if we are doing well for the efficacy, so we don't have clear evidence about it. I don't know if I have answered the question.
Yeah, you did answer it very clearly. Maybe I can actually follow up another question based on the presentation by Casey Lim just now. He was saying that in one of the cases, there is this issue with the CNS penetrations with echinocandin. So in the case of patients who have such embolizations to the brain, what would then be the treatment of choice in patients with Candida the embolizations in the brain? Do you use echinocandin or do you combine it with something else, or how? Casey, do you want to try to answer that?
Yeah, I believe there's no evidence or data on that, I think. Just looking into the pharmacokinetics about echinocandins with the poor tissue penetration to the brain, this is one of the consideration extrapolating from other invasive candidiasis treatment, but then it is difficult. It's all by case series, case reports. So I don't think there's a head-to-head trial to compare on that. Personally, I would use M4B for the CNS penetration, but I don't think it's wrong to continue with the high dose echinocandin as well. So there's no data to suggest one or the other.
Thank you. Does Claudia or Alex have any input on this?
Oh yes.
Not really. Yeah.
No, the pharmacokinetics can be an issue that can help us to decide which kind of therapy we have to prefer for the induction treatment. Yes, it can be an issue that can help us in the decision.
Thank you. I think moving on, I'm just going to continue with the treatment duration. I'll cover the additional question after this. So, so one of the questions is the treatment durations. You did cover it just now, Claudia, but I just want to actually ask this specific question. In patient with IE managed surgically, should antifungal treatment duration be anchored to the timing of surgery, or you just give a finite duration of 6 weeks, or we should actually look at whether the valve that we took out from the patient is positive or not? If it is positive, then does it actually influence the treatment duration where you need to extend? For example, patient who undergo for some reason surgery 5 weeks down the line, so another 1 week to go for the treatment, and then the culture from the valve is positive. How do you manage the treatment duration in this non-prosthetic valve, i.e., native valve, i.e., with by Candida?
I think we can follow the general recommendation about management of endocarditis in general. There is no specific recommendation about this issue in Candida endocarditis, so you cannot look at the guidelines and find the solution specifically for Candida endocarditis. But if we are looking at the general indication for management of infective endocarditis, we know that the surgical procedure and the microbiological results from the valve, it's an important key point. We start thinking about the length of the treatment if it's positive or negative after the surgery. So we restart everything if the cultures is positive. I think we can do the same recommendation as for the general endocarditis. So starting the treatment, the fixed length of treatment if the valve is positive. And also for Candida species, I think we can do that because the risk of relapse, no? So if the valve is positive, we have to prolong the treatment and we have to restart from the beginning of the time point. 0 will be the surgery. So we'll start the induction therapy. We will continue the induction therapy and then decide for treatment for how long should be the treatment after the surgery. As I already mentioned, there is no clear evidence about the duration of the treatment after surgery in native valve. So we don't know how to manage the length of treatment after the surgery in native valve. Someone has said that longer suppressive therapy is needed, but we don't have clear randomized trial and clear recommendation on it. So it's a hot topic, I think.
Thank you. I'm going to actually follow up a question regarding the suppressive therapy because you did mention about it just now, and then one of the audiences asked this question. In terms of guidance on secondary prophylaxis to prevent recurrence due to infective endocarditis, particularly in situation where there is no suitable oral step down option available. How do you do that? How do you manage these kind of patients?
It's for me the question. If I understood well, so the prevention, right?
Yes.
Okay. Quite hard question because preventing Candida endocarditis is quite a hard issue. We have recommendation for the prevention for other pathogens, mainly addressing other pathogens, for example, after procedure in the oral cavity, dental procedure, etc. So the management of the prevention of infective endocarditis in this setting has been addressed by the guidelines. The prevention in invasive candidiasis, it's a very hard topic to answer, and I have not an answer on how prevent a relapse or for prophylactic treatment. We know that the suppressive long-term treatment, it's a kind of prophylaxis, no? It's a kind of way to try to reduce the relapses, but I will not probably call it prophylaxis, only suppressive treatment to try to reduce relapses. And it's quite different concept, but I think it's better to call like maintenance therapy or long-term suppressive therapy than prophylactic agents. And what about the drugs? Okay, for sure, azoles could be an option. I've shown data of the safety of the loss suppressive therapy of azoles. I know the problem is that antifungal resistance is emerging. We have some problems in Italy also for fluconazole resistant Candida parapsilosis, so we don't have weapons for this kind of pathogen. Maybe rezafangin could be a very important tool in the future, also for the pharmacokinetics dynamics, the long-acting dosing, and also the antibiofilm activity. So it can be a useful tool in this setting. I know that not all the countries have access to rezafangin, but it can be a useful tool.
Thank you. I'm just going to pivot back to the detection of the Candida. I have a question here by Fatih, and I think that maybe I can ask Ronzang about this. Are there any circumstances that indicate Candida auris? Does the SDA plus blood sheet agar plus EMB sufficient to diagnose fungal bloodstream infection, I believe from C. auris? Or
Yeah,
can
I'm
you?
actually not very familiar about the lab part. So, yeah, pertaining to what kind of plate, I'm not sure. But yes, generally, if you were to diagnose any of the candida, you do use an SDA bottle. So yeah, that's all I can say. But I believe there might be also molecular diagnostic behind the lab as well when they run the primers and they will see that yes, it's an auris. Yeah. So yeah, usually they do use SDA. And also sometimes when you look at the colony pattern and you turn behind the plate, you can also see how the colors grow. So yeah, sometimes that may be some features of that. So yeah, unless you can ask a mycologist, so I don't have the answer for this. Yeah.
Thank you. Anyone has any answer to this? Casey or Claudia? How do you actually optimize this lab diagnostics?
No addition. It's the same, the correct bottle with the correct volume to be
Okay.
sent. Yeah. So with
Okay.
the technical lab part, I think we need to consult microbiology.
Perhaps I can ask the final question to Casey then, or maybe Claudia, because this is one of the questions that was asked initially. Are there any human study comparing M4B combined with flu cytosines versus amphotericin B monotherapy for the treatment of echinocandin-resistant Candida IE? So I think this is a very, very rare kind of situations.
I'm not aware of any head-to-head comparison studies. There's only case series or there are only case reports. So no, I'm not aware of it. Yeah, the human study comparing head-to-head of these two. Yeah.
Thank you. Claudia, any input on this?
No, I'm not aware of specific studies comparing in the setting of Candida endocarditis, amphotericin B in monotherapy versus the combination therapy. We have some data, as I previously showed you, in observational studies, both using monotherapy from a lot of agents, so not only amphotericin B, and also the combination therapy amphotericin B and flucytosine. And the very old studies that I've mentioned, published in 2005, have demonstrated that the combination that was mostly with amphotericin and flucytosine had been demonstrated a benefit. So we probably have integrated this in our clinical daily life, but the evidence is not so strong. So we should probably consider a head-to-head comparison of the induction regimen, also dealing with combinations versus monotherapy.
Okay. I can see Fatih is turn on his camera. Do you want to ask a specific question, Fatih? No, okay. Okay. Maybe I can ask a personal question to everyone. before we end this session. We have another 5 minutes. Just a practical question that actually might be controversial also. Should we perform fundoscopy in all patient with fungemia or only in patient with complicated fungemia or we suspect complicated fungemia? Because it can also be quite difficult to ask our colleague from ophthalmology to check the eyes of these patients. Though this is not a problem in my center, this might be a problem in another center. Maybe everyone can actually give their short opinion about this. Let's start with Claudia and then Casey and then RX. Yeah.
We should probably start another webinar on it because it's a very highly debated issue. We know that also the incidence of ocular involvement after candidemia, it's quite different from depending on the report. So we didn't even know for sure how is the real incidence of this localization, lipstick localization. It depends on the protocol of the hospital. So we have mainly observational studies, so it depends on how we perform the screening and how we select patients who undergone to the screening. I can answer with the recommendation the latest guidelines. So they have acknowledged this problem. They have acknowledged that we don't have a clear answer about it. So we have to studying it. We have to reach for an answer. But they recommend in the CMM guidelines recommend to do it in case of risk factors. So trying to tailoring the screening on the patient. And for sure doing it in high risk patient, while in some circumstances non-complicated candidemia in a setting without risk factors, we can consider not doing it to everyone. But it's a very highly debated topic also between infectious disease doctors and ophthalmologists that arguing with letters, so it's hard to answer now.
Thank you. Casey and RX, do you guys have any input on this?
I think there's a paper published in 2022 in the ophthalmology journal saying that the rate of positive yield is less than 2 or 3%. So we know the yield is low, but we don't know how to pick up this 2 to 3%. That's the question. So I will go by case basis. In my local setting is a routine. It's a routine. I have to admit it's a routine eye assessment. But I would look at case by case because, for example, invasive candidiasis patients tend to be ill, tend to be in ICU. They tend not to be able to complain any eye symptoms. They can be intubated. So it's more so important for us to screen early. And then the other issue that again, pharmacokinetic again, echinocandins does not penetrate eyeball well. Although some say it can penetrate the choroid valve, but not the vitreous. So if it's choroid, you still can use echinocandin. But if it goes beyond the vitreous, then you need other local the intravitreal therapy or even vitrectomy. So that's another consideration. But in my setting, we do it routinely, but considering that usually this kind of group of patients are very ill in ICU, they can't complain. More so we need to check it early. Yeah.
RX?
For well patient, probably you can ask for the symptoms.
Okay.
Yeah, I mean, like yes, if you don't have a resource for that, then yeah, you may have to go with clinical if there's any complaints, or if you can examine, then you might at least examine your own fundoscope rather than a full eye examination. But yeah, like what Casey said, if the patient is very ill, or if you are using echinocandin and you're not comfortable with it because they can't penetrate the eye, then yeah, probably you would do that. But I do agree the yield is low. If you have the good resources, you can still do because if you miss it, the missing if you miss it, it's gonna be devastating because patient can lose an eye and lose a sight. Yeah, and it's medical legal sometimes. So yes, if I have the chance, I will still do it. I still do it. But if I really don't have the resources, then yeah, I can't. That's all, man. That's what I would say.
Thank you. And sorry to actually end this with a controversial question and make you guys actually say things that might not be comfortable. And I think that from my reading also, doing the fundoscopy early in patients sepsis or critically ill, you can also see septic changes in the eyes. So how do you differentiate this with changes due to fungal infection? With that, I would like to actually thank you all the three speakers for the excellent lecture today and all our participants, 180 of them just now who participated and listened to our webinar today. Thank you. And with that, I end the webinar session today. Bye-bye, everyone.
Thank you.
Bye.